Thank you for allowing me to present. Please forgive my laryngitis. I hope you can understand me. I have nothing to disclose. The NHANES data from 2009-2010 showed that the rate of obesity at a BMI above 30 is approximately equal between men and women. At 35, women begin to outnumber men 1.5 to 1. At a BMI of above 40, women outnumber men 2 to 1. However, in the bariatric surgery population, women outnumber men 4 to 1. The purpose of our study was to investigate this discrepancy and identify disparities in health demographics between men and women presenting for bariatric surgery. We collected data prospectively from 1,368 patients who presented for bariatric surgery consecutively. We collected data on demographic and comorbid disease. We assessed comorbid disease using the Assessment of Obesity-Related Comorbidity Scale, or AORC. This is a scale that ranks severity of disease from 0 to 5. A score of 3, 4, or 5 indicates advanced disease or disease requiring medical or surgical intervention. The AORC collects data on all the comorbidities listed here. In our study, we chose to focus on the highlighted comorbidities as they significantly impact patient mortality and quality of life. Our general demographic results are listed here. As you can see, men comprised 18.5% of our patient population. They were on average older and on average had higher BMIs. More specific demographic data is listed here. Men were more likely to be above 50 than women, and they were more likely to have class 4 obesity. Comorbidity data is listed here. Men were more likely to present for bariatric surgery with diabetes, hypertension, obstructive sleep apnea, and metabolic syndrome. Furthermore, they were significantly more likely to present with advanced diabetes as defined by an AORC score of 3 to 5, advanced hypertension, advanced dyslipidemia, advanced obstructive sleep apnea, and advanced metabolic syndrome. Women were more likely to present with depression and GERD. The figure shown here shows the proportion of men among patients with each comorbidity in relation to the proportion of men in our study. The y-axis shows percentages, and the x-axis shows individual comorbidities. The horizontal line shows the 18.5% prevalence of men in our study. The striped bars indicate a comorbidity of any severity score, and the solid bar indicates a comorbidity, an advanced comorbidity with an AORC score of 3 to 5. As you can see, men present with diabetes, hypertension, and dyslipidemia out of proportion to their prevalence in our study. Additionally, they present out of proportion with obstructive sleep apnea and metabolic syndrome. These results indicate that the male bariatric surgery patient presents older with a higher BMI and with more advanced comorbid disease than his female counterpart. On the one hand, the obese male with advanced age and the phenotype displayed in our study predispose him to unacceptably high obesity-related mortality.
Complex gastrogastric fistula.
However, on the other hand, his age and phenotype as well increase his perioperative mortality risk, potentially resulting in a loss of the mortality benefit typically associated with bariatric surgery. This is the dilemma of the obese male bariatric patient. Our solution? Earlier bariatric surgery for these men may mitigate the consequences of obesity-related comorbidities and optimize his surgical outcome. Thank you.
Dr. Matar.
I think this is a very important study, a very timely one too. I just wondered if the authors had an opportunity to correlate payer mix in these men. Was there a difference in their socioeconomic background as they presented to your practice?
Sam, I couldn't quite understand the question.
So, in other words, did the socioeconomic status of these men affect their approach to your practice, their presenting to your practice?
We did not collect data on their social economics. Is that what you said? Yeah, we did not collect data on their social economics, although there have been prior studies that show that social economics do impact bariatric surgery access and outcomes.
So while this gentleman's coming to the microphone, I'm going to ask, it seems to me like the problem with men is that they just basically don't admit that this is a problem or and will seek help. So did you do any did you have in your psychological evaluations of these people pre-operatively?
Laparoscopic revision of a Roux-en-Y gastric bypass for the treatment.
Why these men did come for surgery?
That's actually a great question. We did not do that in our
Laparoscopic revision
patients,
of a
but there is
Roux-en-Y
a body
gastric
of literature
bypass
looking at
for the treatment
men's
of a
perceptions
complex
of their obesity,
gastrogastric
and it has
fistula.
been shown that across
We
all
present a
BMIs,
36-year-old
men
female
feel
with a
like
BMI
they
of
are less
43,
obese than their female
had an open
counterparts.
gastric bypass in 2006. She started with epigastric pain and weight regain 2 years after the surgery.
One question about the referral. It seems in your study maybe there are more referrals from other doctors rather than because women tend to present to the bariatric surgeon by maybe knowing about the surgery by friends, co-worker. Usually in our practice we see men more by other doctors.
Yeah, I think women do have, because there are more women getting bariatric surgery, you're right, women have more association with other women who have had bariatric surgery, and the men are usually forced there by their doctors. But women also have differential access to health care than men. They have well-woman visits, they see doctors, and so they're getting input from a lot of different areas of their life, whereas men seek health care on a more episodic basis until they develop chronic disease. I think that plays a role as well. Thank you.